share my screen and let's see. Should be there. Perfect.
Yes.
Okay, and we you're in control of making sure everyone gets in, Marika?
Yeah, we have no waiting room. We got rid of the waiting room, and I'm in charge of making sure people that everyone's muted when they need to be.
Okay. Well, thanks so much. Well, I guess we'll get started then. So thanks for joining today. We're going to cover the 6th session of the MSERS series today. The topic came as a recommendation from the feedback that you had provided in the evaluations. We're going to go over a couple difficult cases of the management of hypertension in the nursing station. So we're going to go over that today. My name is Ben Thompson. I'm an associate professor at Queen's, although my clinical work is now in the Toronto area. I have had a bunch of old research grants and have been paid in the past for a talk from Baxter, but none of the content today has anything to do with any of this, so no mitigation has been required. So we are going to cover a fair bit today, and there will be some useful charts as we go that are easy to print for guidance after the session. And of course, all of these are available on the website. So we're going to discuss the approved methods of taking a blood pressure, then discuss what are the risks associated from hypertension in our patients with and without diabetes. We're going to go over blood pressure targets in people with different comorbidities, then the ideal first line and second line blood pressure medication for patients based on those comorbidities. I have a few clinical pearls that can help us with challenging situations that you may be confronted with. We're going to discuss how to identify patients with poor adherence to therapy and a few strategies that we can use to enhance adherence. We're going to discuss how to identify patients who may need to have workup for secondary causes of hypertension, who needs a referral to a hypertension specialist, what lifestyle interventions we can consider, and we're going to go over a couple cases as well. And recognizing that the longitudinal relationship in your communities is predominantly at the nursing stations, because the physicians are often flying in and out and may not be there for longer than a couple weeks at a time, recognizing the essential role that each of you plays in the management of a hypertensive patient. So first off, how to measure a blood pressure. It might seem obvious, but there are some really important considerations here. So firstly, there's generally 3 types of ways that we measure blood pressure. A 24-hour monitor is considered the gold standard. Ideally, this should measure blood pressure over 20 to 30 minutes, every 20 to 30 minutes during the daytime and nighttime. This is the most accurate and is especially good at picking up people with white coat hypertension or masked hypertension. On the other hand, this type of equipment isn't easy to do in all patients. It's largely unavailable in most communities. Therefore, we instead can choose to have patient blood pressure readings in the home or in the office. Having patients do readings at home is the second best choice, followed by pressures in the nursing station, which unfortunately are confounded by the possibility of white coat hypertension or masked hypertension. So if you have a patient that has access to a machine at home, usually what we suggest is that they take a reading at 10 in the morning and again between 3 and 4 in the afternoon. And ideally take this over several days of the week for a couple weeks is considered much more reliable than the office readings. Now, important to consider a few things to avoid prior to taking a blood pressure, regardless of what location the blood pressure is being done. Some of these seem pretty obvious, like pain and stress, but also having a 30-minute break after drinking coffee, smoking, showering is an important consideration. And important to know what medications to avoid. So people who are taking Advil or ibuprofen or Celebrex, the COX-2 inhibitor, these are well known to cause hypertension. So best the blood pressure readings are taken at a time, if you can, without these interfering medications. Now, as far as the technique goes, this is a picture that some places print and put in their examination rooms directly from the international guidelines of hypertension. As far as the technique goes, when the patient does the blood pressure at the clinic or at home, they should be sitting in a quiet room alone with no distractions, with the back supported, feet flat on the floor. Wait for about 3 to 5 minutes, then take 3 readings with a break of about 1 to 2 minutes between readings with the arm at heart level. Now, depending on which guidelines we use, either the average of the last 2 of 3 readings or the average of 3 readings is considered the best measurement. Most of the automated blood pressure machines that you'll have at the nursing station average 3 readings, which is considered acceptable. Now, I'm going to move on to what are the consequences of hypertension. Now, there's entire courses on the evidence-based guidelines between hypertension management, and I'm not going to go over that. There's entire week-long courses about this. So I want to summarize as best as I can the data from all these trials without laboring about the subtle differences between the trials. So this figure summarizes the results of multiple trials of hypertension in patients without other vascular risk, so considered uncomplicated hypertension. So this would be the kind of patient who has on no medications, no past medical history, and just has hypertension and nothing else. Now, what you'll see at the bottom here, these are the names of the trials in bold. You can see 4 of the 5 trials showed significant benefit. Those are the ones that you see in a light gray, and then only 1 of the 5 showed no benefit in the dark gray. And when we say benefit, what we mean by this is reduced vascular outcomes. So it decreased heart attacks, strokes, hospitalization for heart failure. You can see that it appears that the cutoff of 140 millimeters of mercury appears to be where patients seem to benefit in these trials. And this is why for uncomplicated hypertension, the target has historically been 140 millimeters of mercury or less being the goal for hypertension. This is a very similar trial summary figure for hypertensive elderly patients, so typically considered over the age of 65 or 75. You can see that 8 of the 10 trials show a benefit in the primary outcomes. Again, this means reduced heart attacks, reduced strokes, reduced hospitalization for heart failure. And you'll see that the benefit was at systolic pressures higher than 140, making some in the past suggest that the elderly population may not need to be under 140. Maybe, maybe a higher target in this population would be reasonable, although this has recently come into question and the new target is no longer 140. And I'm going to go over that in just a moment here. This is a similar figure looking for hypertensive diabetic patients. You'll notice 7 of the 12 trials show benefit in the primary outcome. Oh, hello? I'm getting some feedback here. Okay. So again, this shows 7 of 12 show benefit in primary outcome, which again is strokes, heart attacks, or cardiac events. And you'll notice that there are a few trials that demonstrate that bringing the blood pressure under 130 shows benefits. And that's why historically, the target for people with diabetes has been 130 systolic or less. And I'm going to go into this a little bit because there are some diabetic patients now who may in fact even benefit from a lower systolic pressure. This is the final summary figure for trials in patients with a history of a past cardiovascular event. So these are patients who've had a past stroke or past myocardial infarction. And you'll see that in the stroke trials, those are the ones on the left, the group of 4 on the left. There was a benefit in future rates of heart attacks, strokes, cardiac events in 3 of the 4 trials. You'll notice that there is clear benefit from about 140 to 130 in the HOPE trial and the PROGRESS trial. And these are the 2 trials that basically formed the basis of using a target of 130 or less. On the other hand, it looks like possibly the magic target of 130, maybe there's benefit even further than that. You know, there was some debate about the targets for quite some time, but basically we can summarize prior to 2018, the targets were quite simple. If you had uncomplicated hypertension, or if you were elderly, the target was 140 on 90. If you were diabetic, regardless of age, or if you'd had a past cardiac event, the target was 130 on 80. Now, things have gotten a little bit more complicated as a result of probably the single most important trial in hypertension for decades. And I'm going to go over that a little bit. So there was considerable debate about whether it would be harmful taking blood pressure under 140 systolic in patients with uncomplicated hypertension or in patients without diabetes. Oh, someone's got their microphone on.
Were you guys having a party?
So sorry, I can't mute. I've been kicked off. So if one of the other practice consultants are online and you can have the ability to mute, could you do that?
Yeah, I sure will. Just one sec. How do I do that?
I'm not sure you will. If there's anyone else logged on as Sue Lookout, I'm thinking they might be able to. My computer has kicked me off.
Okay. It looks like it's quieted down. So I'll go back to the chat. So there were some concerns that bringing blood pressure too low may lead to more expensive medications with side effects, more visits to the doctor, more monitoring, may increase serious effects like acute kidney injury, falls, fractures. So there was considerable discussion about whether our targets were appropriate. In response to this, there was what's called the SPRINT trial, and this confronted some of these challenges. Now, I don't usually like to go through specific details of trials, but the Canadian and European and international guidelines have all changed based on this single trial. So because they've changed, practitioners need to know what types of patients would have been included in this trial to understand the new guidelines. So as such, I've included it here. The trial included patients who were 50 years of age or over with hypertension based on the systolic pressures that are listed there. And they had to have one additional high risk factor, which could be chronic kidney disease, age 75 or over, or an additional risk factor like dyslipidemia or obesity. Patients were randomized to a systolic pressure under 120 or to intensify antihypertensive management only if they had one visit with a systolic over 160 or two visits over 140. So the first thing here is that very clearly there was a significant difference in blood pressure between the groups. The intensive arm average was about 121 systolic and the standard arm was 136. And this is what the outcomes were. And this is why the guidelines have changed. So the figure on the left shows the primary outcome, which was the combination of heart attack, coronary syndrome, stroke, heart failure, or death from cardiac causes. And you can see there is a significantly lower rate of all these outcomes in patients with intensive therapy. I can't mute whoever's in the background. So if someone wouldn't mind trying to mute all, that would be great. You can see there's a significantly lower rate in the patients treated with intensive therapy. And then on the right-hand figure, you can see that death from any cause is less likely in the intensive therapy. So in non-diabetic patients who are 50 or over with one additional risk factor, targeting a blood pressure systolic under 120 rather than 140 led to better survival and fewer cardiac events. So that single trial changed the guidelines. So this is an important consideration though. Even though the intensive arm aiming for 120 or less had less death and less cardiac events, they do have higher rates of side effects like hypotension, syncope, electrolyte abnormalities like hypo and hypernatremia, and acute kidney injury. So these are important considerations. So yes, we achieve better blood pressure control and decreased death, but the patients do suffer a little bit more if we try to achieve this. So that's a consideration. So if we take this trial, what are the current targets? This is our summary slide, and this summary slide tells us what our current targets are. So this is the Canadian Hypertension 2020 guidelines, which includes an update based on the SPRINT trial. So for any patient who's considered high risk, this means over the age of 75, high risk Framingham risk score, which can be calculated easily online, or one other risk factor. Those patients should be started on blood pressure medications if their systolic is greater than 130, and the aim should be to get it under 120. The target in patients who are diabetic remains less than 130 on 80. Now, low risk patients meaning uncomplicated hypertension, these patients should have treatment started if blood pressure is over 160 on 100, and we should aim for less than 140 on 90. The bottom line here is if they qualified for the SPRINT trial, aim for 120 systolic. If they're diabetic, 130 on 80. And if they're low risk, meaning no diabetes and no cardiac risk factors, aim for 140 on 90. Now, what drugs should we use? There's in the actual guideline document, there's about 20 pages on this. This is a one-page summary of everything from those 20 pages. So you'll see here that most of our patients fit into one of the top three categories: hypertension with no other comorbidities. So in that situation, you can use an ACE inhibitor or ARB, beta blocker, or thiazide. And then if the blood pressure is still not on target, you can combine those first-line drugs. You'll notice that any of the other categories suggest that you can have an ACE inhibitor or ARB within your first-line therapy, dictated by the underlying condition. Certainly there's other drugs within the first line, but every single one here has ACE inhibitor or ARB as a first line. So I'm not going to go through the evidence of every single line here, except to provide this as a guide to you to know where to start and what kind of drug to use when. So a few things you don't see on this chart, and a few things I'll go over now with the clinical pearls. Avoid alpha blockers whenever possible, especially in the elderly. It increases the risk of falls, of orthostatic hypotension. It actually worsens outcomes. So definitely, unless the patient has prostatic enlargement, really there's no reason to give alpha blockers for hypertension. Short-acting nifedipine, that is often required to take several times a day. This is no longer considered acceptable therapy. This is basically contraindicated. It's now known to cause an unpredictable fall in blood pressure and can actually precipitate ischemic events. So best to be avoided. You can use other calcium channel blockers like long-acting nifedipine and amlodipine or felodipine are considered acceptable antihypertensives. Because we use a lot of ACE inhibitors or ARBs, some of these patients will develop hyperkalemia. One of the ways to counterbalance that is to co-prescribe a thiazide diuretic, or if they're diabetic, an SGLT2 inhibitor such as empagliflozin or canagliflozin. And that can balance the hyperkalemia. It's a handy little thing to use. And then finally, do not combine ACE inhibitors with ARBs. That's considered generally contraindicated. That dramatically increases the risk of severe hyperkalemia and doesn't provide them with any long-term benefit. So best to avoid that. Okay, so we're going to move on to adherence. So when we think about adherence, it's even difficult to know what the definition of that is because the studies differ. But in general, 1 in 3 patients takes less than 80% of their prescribed medications. So there's a few ways to assess adherence. Certainly, if you have the time or resources to do pill counting or to call the pharmacy and ask them when the prescriptions were last filled, that's great. Most of us don't have time to do that. So instead, I use an interview technique that has actually been confirmed to be more predictive of adherence than traditional techniques, like simply asking, do you take your medications? So changing the way that we ask the questions about taking medications actually predicts adherence. So asking instead, when you feel like your blood pressure is under control, do you sometimes stop taking your medicine? Or asking, how often do you have difficulty remembering to take all your blood pressure medication? Or better yet, taking medicine every day is a big inconvenience. Do you feel hassled about sticking to your blood pressure treatment plan? This style of interviewing yields better answers that are actually more predictive for adherence and gives the patient permission to be honest, which opens up a conversation that can lead to better education about why they're taking their medications, which further enhances adherence to their medication plan. So I tend to ask one of these three questions instead, and they're actually evidence-based to improve adherence. So it's a good thing to integrate, and it can easily be done. This is a simple chart from a study in which antidepressants were prescribed, and the dosing amount was strictly recorded by pill count. So they had a very good way to assess adherence. And as the dosing frequency of the antidepressant increased, the adherence rate went down. So no surprise. So for every extra dose per day, the adherence went down about 10%. So pretty significant drop. So then when we consider strategies to enhance or to improve adherence, there's many that now have evidence base. So if you have confirmed that a patient is struggling to take their medications as prescribed, using the questions that I've provided on the last slide, there's a number of ways we can do this. So simpler once daily dose regimens are superior to multiple daily dosing. There's a whole bunch of other strategies though. So encouraging the use of pill boxes or blister packs, using a team-based approach is really crucial. So communicating with not just with the prescribing physician, but also by supportive nurses and pharmacists. And I think this is especially important in your communities because that longitudinal relationship with the patient is not typically with the physician, it's typically with you. It's typically with the nurses and the pharmacists. So important that you guys are playing the essential role there. Providing patients education about why they're taking the medication and potential risk of the medications helps, and borrowing your pharmacist to be involved in that at the point where they pick up their medications can be really helpful. Lowering economic barriers to patients helps in as well. And finally, this is a funny one. So sending the prescription directly to the pharmacy by faxing it or through the electronic medical record if they have access, that actually improves adherence. So it's been shown in a number of studies now that if you hand a patient a prescription in your clinic and have them walk to the pharmacy, that simple expectation decreases adherence. So better to actually get it to the pharmacy that then coordinates contacting the patient, so long as the patient knows to go pick up the prescription. So, so moving on from that, so about 5 to 10% of patients have hypertension that's secondary to an endocrine problem, like sleep apnea or hyperthyroidism or some other condition. This is called secondary hypertension, and we have to think about when this is important to identify, because these patients often need subspecialist referral and management depending on the cause. So we should think about certain patients for this. So if they previously had stable blood pressure and then all of a sudden have severe hypertension, that's a sign of secondary hypertension. If they have early onset hypertension before the age of 30, this should also be considered. If their hypertension is resistant to high doses of at least 3 antihypertensive medications, with one being a diuretic, this is considered resistant hypertension, and a higher percentage of these patients have secondary hypertension. If they present with a hypertensive urgency or emergency, meaning the systolic is over 180 or the diastolic over 100, this is a urgency. And if they have end organ damage like confusion from encephalopathy or acute kidney injury or aortic dissection, this is considered a hypertensive emergency and should also raise concerns for secondary hypertension. And finally, some patients present with a classic presentation for a cause of secondary hypertension. So the patient that you have in your nursing clinic that is morbidly obese, his wife is constantly complaining that he snores really loud, he's always falling asleep during the daytime. There's a pretty good chance that his hypertension is at least partially secondary to obstructive sleep apnea. So need to think about that as a possible secondary cause of hypertension. So when are we going to refer a patient from your community to a tertiary center for hypertension, to a hypertension specialist? Well, there's no guideline-based referral criteria, but there are some widely agreed upon conditions under which this would be reasonable to refer. So if you're considering referring to a hypertension specialist, there's a few. So if you suspect a patient has white coat hypertension or masked hypertension, this would typically require someone to have a 24-hour blood pressure monitoring, which would typically be done with the hypertension clinic. Alternatively, patients with secondary hypertension should be referred, or patients with resistant hypertension. And again, that means 3 antihypertensive medications at high doses, one of which is a diuretic. Any of these would be considered very reasonable to refer to a specialist. Now, the bottom picture here again, that's what a 24-hour blood pressure monitor looks like. Very useful device that hypertension specialists will use to identify patients with white coat or masked hypertension. I'm told that at least 1 or 2 of your communities has access to such a device in your community. That's impressive because admittedly, even in the Toronto area, we can only access this through the hypertension clinics. So certainly would, and even if you had one in the community that was shared, that would be quite a useful device. Now I see that there's a question in the chat. Please repeat the values for hypertension emergency. Yes, so any systolic greater than 180 or any diastolic greater than 100 with end organ damage is considered an emergency, whereas the absence of end organ damage would be considered an urgency. Both of those would be considered reasons why you might want to consider someone for secondary hypertension. So 180, I'll put it in the chat box here, 180 systolic and 100 diastolic. Okay. All right. So where are we here? Okay. So other things that we can do for our patients with hypertension. So guidelines recommend lifestyle interventions as part of the overall strategy that includes hypertension management in patients above target. So these include things like reducing dietary sodium, weight loss, restricting alcohol consumption, increasing physical activity, smoking cessation, weight loss. Now, I'm aware that the food choices in many of your communities simply don't permit ease of changing salt intake or to committing to a very restricted or specific diet. But some of the other choices here may be considered, such as reduction in alcohol, weight loss, increase in physical activity. I will make the DASH diet available through the website. Having reviewed it, many of the foods that are suggested in this diet are simply not available in your community. So I add it there for interest. Certainly, even if a slight modification to diet as far as reduction of salt and moving closer to the DASH diet can be made, that's helpful, but acknowledging that the very challenging circumstances we work in is going to make full adherence to that likely pretty impossible. So we're going to go over a couple cases. So this is Judy Nakaji. She's a 54-year-old woman. She lives in Attawapiskat. She's got long-standing diabetes with retinopathy, hypertension, dyslipidemia. She's got coronary artery disease with a heart attack in 2017. She's obese. She's got COPD, ongoing smoking of a pack a day, and she has pretty severe osteoarthritis in both of her knees. She has normal kidney and liver function. She's on a statin, aspirin, metformin for her diabetes, and she takes Advil a couple times a day for her knee osteoarthritis. She's in clinic and you check her blood pressure, and the average of several readings is 152 on 93. You confirm that her body mass index is 56, confirming morbid obesity, and the remainder of her exam is completely normal. So a few questions here. Firstly, given what I've described, what is her target blood pressure? Secondly, what blood pressure drug would you start with? And what would be the second drug you would add? Thirdly, what medication regimen would you use to enhance adherence? And fourthly, what lifestyle interventions might you recommend for Judy? So we're going to go through these one at a time, and we'll go over the same charts that I've shown before. So target blood pressure. Okay, so if we go back to this chart, she is diabetic. So on the second line down, it looks like her target probably is 130 on 80. But is she a high-risk patient? So on the top one, does she qualify for being a high-risk patient? So based on the Canadian guidelines, she actually is a high-risk patient because she, let's take a look here, where are we here? So high risk requires her to have one of the four following things. So chronic kidney disease, so she doesn't have that. Framingham risk, we haven't calculated that. She's not over 75, but she has had a previous myocardial infarction in 2017. So she is considered high risk. So you could choose to do the target of less than 120 systolic because she's high risk, or 130 on 80 because she's diabetic. Either of those would be reasonable. What drug would you use? Well, if we look, oh, I'm hearing some voices there. If you wouldn't mind just muting your microphone. So which medication should we be using? So let's look at the table, and she fits into two of these categories. So she has diabetes with complications, so that's the second line down. And she also has coronary artery disease, which is the fourth group down. So she could choose to start ideally with an ACE inhibitor or ARB. And then depending on how well we do with that, if she needs additional therapy, we could add a calcium channel blocker, beta blocker, or a thiazide diuretic based on what we're looking at here. Okay, so the other nice thing here is if she's starting an ACE inhibitor or ARB and she develops mild hyperkalemia, you can always counteract that with a thiazide diuretic. So how are you going to improve Judy's adherence? So there's a couple things. Again, we'll go through this. So you want to use a once daily formulation. For ACE inhibitors, both ramipril and perindopril are once daily. For beta blockers, bisoprolol or atenolol can be given daily. And thiazide diuretics are typically dosed daily already. So indapamide, hydrochlorothiazide, those are already once daily formulations. So that's easy to give all in one go. We would want to have her medications ideally bubble packed. We'd want to involve the pharmacist in the education process. Make sure the pharmacist is sent an electronic copy of the script whenever possible. So Judy could also benefit from some lifestyle interventions. So while it would be difficult to do all of these at once, and it may require more than one clinic visit, she could cut down on her smoking. She could add some exercise and walk every day. She could try to lose some weight. You could ask about her alcohol consumption and salt intake to see if there's a way to reduce that. This is a really important role for the multidisciplinary team to play, again, since the physician sees for hypertension, but's pretty much gone when you need to deal with everything else. So you're often left with the consequences of the physician's decisions well after they've gone. The other intervention I should mention is the ibuprofen. So it's important to review her medications that can precipitate hypertension, as if you stopped her ibuprofen, that's about as good as starting an antihypertensive medication. There's a whole long list of medications to consider, including weight loss or flu medications that contain the stimulants ephedra and pseudoephedrine. Some antidepressants, such as amitriptyline, fluoxetine, are known to precipitate hypertension as well. Caffeinated beverages like the energy drinks that some kids are drinking loads and loads of, as well as illicit drugs like anabolic steroids, stimulants like cocaine and amphetamine. These are important to consider, especially in younger patients with hypertension. So what blood work should you order for Judy? Well, this is actually, there's a very nice summary recommendation in the Canadian guidelines that states for patients with hypertension, investigations should include urinalysis, serum electrolytes, serum creatinine, fasting glucose, lipid panel, and a 12-lead ECG. So if you have a patient with hypertension for the first time, this is what you should be ordering. Now, the last time I did a talk similar to this, I was asked, well, why aren't we testing for albuminuria in all of these patients? Good question. If the patient has hypertension alone without diabetes, there currently is no recommendation to check that, but if they do have diabetes, that should be checked. So to be honest, I pretty much order it in everybody because I'm a nephrologist as well. So not unreasonable to order just a simple urine albumin to creatinine ratio in addition to what's recommended here. Okay, let's chat about the second and final case. This is Dakota Bushy. He's 29 years old. He lives in Red Lake where he works in the mines. He comes to the health center for his annual physical. He's a pretty healthy guy. He's got no significant past medical history. He's got no known liver disease, kidney disease, heart disease. He's on no medications. He's got no medication allergies. His average blood pressure done in the clinic is 191 over 112. This is repeated several times, and again, it comes out at approximately the same level. His examination is unremarkable. So a few questions for Dakota. What's his target blood pressure? What antihypertensive should we be giving him? Does he require a workup for secondary hypertension? And does he require referral to a hypertension specialist? So let's talk about the target first. So he is uncomplicated hypertension in the sense that he's got no past medical or surgical history. He's got no cardiac risk factors as far as we know. So he would be considered in the low risk category at the bottom here. So that means that he should be started on medication if his blood pressure is over 160 over 100. It is, so he's going to need to start medications today. And we should be aiming for a blood pressure less than 140 over 90. In Dakota's case, he has hypertension without other comorbidities. So that's the top line here. So we can use any of ACE inhibitors, ARBs, beta blockers, or thiazide diuretics. Now, I try to avoid using beta blockers in young men as it has a very high likelihood of causing erectile dysfunction. So I usually offer a diuretic pill or ACE inhibitor or ARB, and you would almost certainly need more than one medication to get Dakota into target. So the next question was, does he need a workup for secondary hypertension? So quick answer is yes. And if we remember the criteria here, he's had an acute rise in blood pressure with previously stable readings. So he was not previously known to be hypertensive. His hypertension is early onset, so he's younger than 30. And he's presenting with a hypertensive urgency with systolic over 180 and diastolic over 100. So he definitely needs to have a workup for secondary hypertension. Now, does he need referral to a hypertension specialist? Well, you suspect secondary hypertension, so yes. You don't know if he has resistant hypertension because he would need to be on 3 high doses of antihypertensive drugs with at least one of them being a diuretic. So you're not there yet, but he could have resistant hypertension, but you have a very good reason to refer him to a hypertension specialist. So definitely that would be the next step I would do. So that concludes the cases and hypertension discussion. What I was hoping to do would be to answer some questions from this hypertension discussion. And then I wanted to run a few things by you about this series to assure it's meeting your needs and relevant to the context in which you work. So why don't we take the next 5 or 10 minutes? And I'm just gonna, I don't know if I'm needing to stop sharing for us to unmute everyone, Marika, I'm not sure.
No, people should be able to unmute themselves.
Oh, okay, perfect. So I have a couple questions in the chat box. The first is how many readings over how many days to rule out white coat hypertension? So typically with white coat hypertension, what we try to do is we try to make sure if the person has access to a home blood pressure machine that they're measuring it at home. We tend to ask them to measure it at about 10 a.m. and between 3 to 4 p.m. on several consecutive days in the 2 weeks leading up to the clinic. And that allows us to have good measurements. And then if you compare it to the clinic readings, the readings that he has in the clinic, then that comparison can confirm white coat hypertension. If we have access to a 24-hour blood pressure monitor, that is also very helpful because that gives us a higher degree of confidence that outside the clinic, the blood pressures are actually much better than in clinic.
Can I ask a bit of a question, or maybe just a comment from the people in the group?
Yeah.
So we don't have a lot of at-home blood pressure monitoring happening.
Right.
My understanding is non-insured does cover blood pressure monitors for individuals. Has anyone had success in getting one of those units to a community and to an actual person for in-home monitoring? And are there any barriers?
Marika?
Wait, what's going on?
Yes.
Carolyn?
Yes. Hi.
All the time. It's a constant flow of blood pressure cuffs, and people are getting them and people are using them. And it's been great. It was only not that long ago, it kind of occurred to me that they were covered. So remedies anyway, it's a steady stream of blood pressure cuffs coming up here.
That's great, Marilyn. Thanks for letting us know. That's great.
Yeah, I was going to add on to that. This is Ben. Yeah, I do get it through remedies for everybody I prescribe for or request for.
Okay, so that's something as nurses you can, if someone's unfamiliar, you can maybe suggest to your NP or MD.
The big issue, and Ben, you probably would probably agree with this, is getting the readings back to the provider so that you can actually titrate the blood pressure medications. You know, it's always that loop that figuring out how to get those readings back and doing it in an efficient way where the person doesn't always have to come back for an appointment. Like, are there other ways that patients can be in touch with us, whether it's texting or Facebook messaging or whatever? I mean, this is a common thing with all kinds of things, but how do you efficiently do that so people can just like with sugars, right? With diabetes.
Yeah. No, it's a good question. So for many of my patients that I follow for resistant hypertension, what I'll ask them to do, I provide them with a yellow notebook, kind of like the same notebooks that patients have for their warfarin monitoring, where they can write down their INRs in the book and the dose that's recommended. And they usually would get a call from the warfarin clinic, and they simply write down in the book their next warfarin dose. They would have a very similar book and just write down their blood pressures, and they know to bring that book in anytime they come to clinic. And the other option there is with that notebook, if the clinic gives them a call, they know just to get the notebook and read off the readings that they have at home. I've had some success with that, although admittedly it varies heavily depending on the patient's level of motivation. Are there any other suggestions on how to enhance getting the readings back for patients? Okay. Were there any other questions with regards to the hypertension management in your communities?
I'm going to make one more comment. I know we have a hypertension flow sheet that many nurses don't use. They don't like because it's requesting a lot of sort of extra information. So there will be in the next few days just the old blood pressure monitoring tool where you can just list all the values. And it will have the diagram that was shown in this presentation of how to set people up, as well as sort of brief instructions for other nurses who might be unfamiliar, or if it's your clerk doing it.
That sounds fantastic. And if you wanted, Marika, I'm more than happy to post that as well with a link to that on the site. I might actually add the remedy. It sounds like that remedy is a great resource for people. So I'll mention that on the site as well. Is there a specific form that's completed for remedy, or a specific way that you access that? Because I'm happy to post that in the central location that everyone can access. Does anyone have a mechanism of contacting remedy that that they can share with me?
Ben, it's one of the pharmacies, and I believe all of the pharmacies will do this because it's covered by non-insured. So whatever pharmacy a community uses, you just actually send a prescription and say,
oh, okay, okay,
EP cuff, and they use the ones that I believe the CHEP guidelines and recommend. So they use the recommended ones that are in that big list that I used to give to patients when they were buying it themselves. But now, because the pharmacies cover it, so it's any pharmacy, I believe we're referencing remedies because it happens to be the ones that the community Ben works in and I work in, both use remedies. Yeah.
Okay, that's great. Fantastic. Good. Okay, I see another question here. Please feel free to note if patient adherent to meds, the list of what they are taking and their BP values, and we can titrate meds. Oh, okay, yeah. Okay, that sounds good. Were there any other further questions or comments?
Hi, Dr. Thompson. I had a question about combination therapy for managing hypertension. I've had differing opinions from different specialists that say to use a combination medication, such as an ACE diuretic combo, and then I've had others say separate them out because if you have to adjust the medication based on the readings, you don't know which one is needing to be adjusted. Could you speak a little on that?
Yeah, no, it's an interesting question. So the guidelines actually recommend to use a combination drug. I've had quite a lot of success in getting patients' regimen simplified by doing that. So especially for the patients that are going to need more than one antihypertensive medication to get their blood pressure in target, you can give them a combination pill, which is essentially giving them two antihypertensives. And usually the combination pills also allow dose adjustment within the combination. So for example, the perindopril and dapamide combination, there's a combination for 4-1.25 or 8-2.5. So it does allow dose adjustment within the single dose, which I find, I mean, even for the patients who you don't have concerns about adherence with, it is certainly simplifying their regimen. And the guidelines actually suggest to use a combination where possible. So not an unreasonable thing to do at all.
Thank you.
Yeah. There's a question about, in the last hypertension urgency case, why was calcium channel blocker not listed as a first-line option for him? Yeah, so that's an interesting question. So when I presented the case, I was discussing it from the concept of managing the long-term hypertension, but not managing the hypertensive urgency. So if this was a patient that was coming in for chronic management of hypertension as uncomplicated hypertension, in that situation, the ACE inhibitor, ARB, beta blocker, or thiazide diuretic would be considered first line. On the other hand, the fact that he has a hypertension urgency, and I didn't go into this detail, if he was going to require workup for secondary hypertension, sometimes I would intentionally choose medications that would not confound the results, meaning would not interfere with the results of that workup. And in that situation, a calcium channel blocker is a good choice for that reason. But I didn't go over that because that was a level of detail I chose to sorry, I should have mentioned that quickly. Okay. Let's see. Oh yes, so the evaluation for today, I believe that's Marika has posted. The evaluation for last week's session with regards to vaginal pain is also posted. I would encourage you to complete these evaluations, and a certificate of attendance will be provided as well. There's a there is a section in the evaluation to ask for additional topics. So I'm going to quickly share my screen again so that I can show you the next part. Just one sec here. This is just a couple quick slides here I want to go over with you guys. So sorry. Okay. So I just wanted to go over, we need more topics. So basically what we're looking at is there'll be a break from over July, sorry, most of June, July, and part of August. We're going to be starting up the sessions again towards the end of August to June 2022. I want to make sure again that these topics remain relevant to you and are specifically applicable to the circumstances in which you work. So all the recorded sessions are available online. Because of the feedback we've received from you, the slides are going to be available 24 hours prior to the session. I understand that some of you are actually connecting by telephone, which means that you need to be looking at the slides offline. So it's taken us a bit of time to convince presenters to do this, but the sessions are available 24 hours ahead of time, and that's something that we're going to stick to moving forward. The evaluation you'll see there is, please complete the evaluation for your certificate of attendance, and also please let me know additional topics that are relevant to you that we can get set up for the after the summer break. It'll take us a little bit of time to get the right speakers and to get the stuff organized. So the sooner you can let me know about the topics, the sooner I can get them organized for you. Okay. Perfect. Okay. I had nothing else listed here to go over. Marika, did you want to touch base on a couple things? I think you wanted to go over the format as it relates to getting input for the next week session.
So I last time when we had a contraception presentation, the people in the group offered some really good suggestions for upcoming presentations. So our next presentation will be about diabetes. I did reach out to a few people about sort of target areas or specific cases that they might be interested in sharing that could add value to the presentations, and I haven't really heard back from many people. So I was wondering if there was areas of diabetes that were of interest to people or specific things they had questions about.
Marika, it's Marilyn. I would say, I mean, this is something looking at evidence therapeutics and choice of therapeutics now that we have this massive explosion of different hypoglycemic agents, how to choose. I mean, you know, it's if the person's got diabetic retinopathy, do we have to be concerned about, you know, semaglutide, if somebody's got this and pancreatitis history, just being able to choose agents now is way more complicated, including whether we should even be using sulfonylureas, what's the evidence now, etc. That would be super helpful, especially as a physician who's been practicing for, now 25 years. It is a quagmire of confusion in my mind. How to kind of, with evidence, escalate people's uses and compounding, how many agents can you use, etc. So that personally would be really helpful.
Okay, I'm scribbling down your suggestions. I think that's great. Yeah. I would also like someone to explain to me when I should be giving sulfonylureas, because I almost never prescribe them anymore.
Yeah, and see, that sort of stuff, Ben, is super helpful. And also the use now, it seems, of looking at insulin levels and whether that's even a thing that we should be doing. Is there a burnout time that, after a certain number of years, you should just drop it? Does it matter if someone's had a pancreatectomy and they're early on insulin? Can you layer other things on, like all of these comorbidities that make this challenging?
Right. No, that sounds fair. Were there other suggestions for the diabetes discussion that Dr. Sidhu will be doing on June 10th? Okay, now Marika, the next session is May 13th with regards to the pap smear, and then after that's going to be vulvar discharge and pruritus. Were there suggestions on what needed to be included in those sessions at the last session with contraception?
So we did talk about the PAP one,
Right.
and I believe it was the same presenter who did the last session who will be doing the pruritus one. So there was some information shared about those. I'm not sure if everyone was on the line at that time.
Okay.
Are there specific ideas from anyone in the group in those areas that they would like to hear?
For the pap smear, are there any suggested things that we should cover in that area that I can feed back to Dr. Roberts?
So we are starting that out next week with Cancer Care Ontario coming to talk about the new recommendations for sort of the age change and things like that. And then we'll move on to a bit more technical the following week.
Okay, no, that sounds good. Okay. And with the vulvar discharge and pruritus, was there anything specific that Dr. Francis should cover there that would be relevant to your experience? Okay. Rebecca, I got your comment in the chat box. I've added it onto the list.
If you have ideas in any of those areas and you either can't unmute or aren't comfortable, you can send me an email. I feel like I've had a number of people interested in the sort of the general itch area. So
fair enough.
Yeah, I feel like there's lots of we see lots of different presentations. So yeah.
No, that sounds great. Now I'll post the website in the chat box. Probably worthwhile to put it as a bookmark so that you have access to all the talks and stuff in advance. Please do complete the eval, and if you have suggestions for the future sessions that you don't feel comfortable sharing, again, you can do that in the evaluation. I'll make sure that gets to Dr. Francis and Dr. Roberts. Okay, but okay. Did I miss anything, Marika? You're always very good at reminding me the numerous things that I'm always missing, keeping on top of things.
No, I think we're good. If there's no sort of questions or final comments from the group, I think we can end for today.
All right.
All right. Thanks, everybody.
Thanks very much, guys, for your input. This is great. Thanks much. Okay.
Thanks.
Thank you.
Bye-bye.